When we very good evening to all, and this is the presentation regarding the GOI initiatives regarding blood disorders. So, as we understand that blood disorders imposes a heavy burden on families and the health sector in India, a big cause of morbidity and mortality. That's why we all are here to address the issue. Despite improvements in therapy, death rate in this contemporary sample of transfused adult subject with THAL or SCD, that is sickle cell disease, is 3 times greater than the general US population. So when we talk about the sickle cell disease, it's a group of, we understand it's a group of inherited red blood disorders with SCD, the hemoglobin into stiff rods with the red cells. The cells are supposed to be dish-shaped, but this changes into the crescent or sickle shape. So this is important to know while people have been joined with us who should know what is exactly the sickle cell disease and why we are talking about it. The sickle cell shapes are not flexible and cannot shape each time. Many of them burst apart as they have to move through blood vessels. The sickle cell usually only lasts for 10 to 20 days instead of normal 90 to 120 days. So we all understand what is sickle cell disease, and sickle cell affects millions of people throughout the world and is particularly common among South Africa, Caribbean, Central America, Saudi Arabia, Indian and Mediterranean countries. So understanding the thing is that we have to understand in a way that our countries are equally affected with sickle cell disease, and till date we are able to take much of the care, but still we have to struggle a lot. So in India, we see that around 10 to 15,000 babies with thalassemia major are born every year, and sickle cell disease affect tribal groups as well as some other communities in center states such as central, western, north, and southern parts of India. So now you can see now it has been affected in all the regions. It's not only that some central other earlier it was said that these are affecting only tribals and all, but now it is not like that. Because of migration, it has been infected with the other parts of the country. The healthcare of costing of caring of these patients are chronically ill patients are substantial. So the cost, when while we are doing the cost estimation and other things, it's very difficult to understand because the cost is pretty high, and the government of India has though taken the initiative, but still it is very high. So if you can see the disease burden that in India, beta thalassemia is prevalent across the country. An average frequency of caries being 3 to 4%. A high frequency has been observed in central communities such as Sindhi, Punjabis, Gujarati, Bengalis, Maharas, Koli, Saraswat, Lohanas, and Gauls. Why I'm also talking about thalassemia? Because when we talk about our sickle cell, it is not an individual program. It is concerned with hemoglobinopathies, and hemoglobinopathies consist of thalassemia, sickle, and other variant hemoglobins. So this is important that we should understand the disease person where the thalassemia is more high, or where we have the concern for the sickle cell disease and for HBE as well. So HBS is highly prevalent. We say that hemoglobin sickle is highly prevalent in tribal population of southern, central, and western, reaching as high in 40% in some of these, 48% in some of the communities. So in like in Chhattisgarh, I have been to Chhattisgarh, I have been to Telangana, and some of the tribes is going up to high up to 48. Even in Odisha, Dr. Jina is here and he will very well agree that in some of the communities, the Bulla belt, it is consists of 48% of the people who are affected with this disease. HBEs, as we understand, is carrier frequency is high as 50% in some areas and found in lower frequency in eastern states of Bihar and Uttar Pradesh. So in blood disorder, India has the largest cohort. Up now you understand that we have 27 million new birth in 2010. The country has the second largest global population of 1.21 billion and a high birth rate of 21.8%. Genetic disorders arise in the population through spontaneous mutations and through affected birth in families with known risks of genetic disorders in absolute numbers, and with birth prevalence of genetic disorders is likely high to be in India. Whatever we have the estimations, they are only estimation because till date only ICMR has done some of the surveillances which has been done in some of the communities, not even in the entire country. So we cannot say that these estimations are totally there, but still we can say, we can estimate that this is the disease burden, and thus blood disorder plays a great burden on healthcare services. You can see some of the pictures which I have taken from my own hospitals, which is very important. The patient with sickle cell and then thalassemia, hemophilia. So now you can see the prevalence of hemoglobinopathies in India. This map you can see in our guidelines, which is for the prevention and control of management of hemoglobinopathies. You can see this, and this map says that you can see most of the states are being affected with this disease. So, what is the WHO goal? When we were trying to have our own program of hemoglobinopathies, we came to see, we were knowing what exactly the WHO or basically the World Health Assembly is talking about. So, WHO clearly outlined the goals for control for hemoglobinopathies. They said that to provide affordable and adequate therapy for those affected, reduce the number of children with the disease through strong political, administrative, and financial support. So the number of births can be reduced only while we do start doing the screening parts and all. The overall goal of the strategy is to promote and protect health through precautions, early detections, medication, health eating, and physical activity. So you can see that World Health Assembly resolutions in 2006, World Health Assembly passed a resolution urging member states to develop and implement reinforced comprehensive national integrated programs of prevention and management of hemoglobinopathy. And India was one of them. And the member states were also urged to develop and strengthen medical genetic services and community education and training, which was very important. And keeping these principles in mind, we came to develop our own strategy. Dr. Jenna was part of it. I hope he remembers that. And so, what was the mission of GOI? What was the mission of NHM? To provide a better future for all thalassemia, sickle cell disease, and hemophilia patients and their families. We are also talking about their families because it's equally important when we talk about our patients, their families are equally affected with that. So, this is important that we talk about the mental trauma of their families also to lower the prevalence of hemoglobinopathies and hemophilia by reducing the numbers of children affected. So, how can we reduce the number? That was a challenge to us to provide optimal treatment to those affected. Now, the concern was those who are already affected. It is not their fault and prevent the birth of further children with disease through carrier screening, genetic counsel, and prenatal diagnosis. Where the facilities has already been started. I think Dr. Jina knows about it that they have started with the prenatal diagnosis services, and many of the states we have started with the prenatal diagnosis services, and especially the aims are the centers which will be initiating these services for in each and every state. The new initiative and vision under the National Health Mission provides a golden opportunity to administer adequate therapies for those infected, making them lead a better life. So our concern was that if we give the medication or we do the monitoring of these patients, but the rehabilitation part is equally important for these patients so they lead a normal life. That is very important when you talk about the patient, any patient. Our concern at the government of India is any patient who is working, who is suffering from the disease and blood disorders like aplastic also and other diseases which are not able to be cured as soon as possible. So rehabilitation is one a chance where you can get them lead a good life. So we also did a health economics, and we find that this prevention was far better than the management part. So when we started looking at these health economics, and there was a study from Dr. Roshan Kola, who is supposed to be the ex-director of NIH, National Institute of Immunohematology. She did a study and she said ki it is basically if we start doing the prevention program, the per capita income and everything was checked, and we found that it is coming to more than that. So the per capita income, which was very less, and the compared to the management it was quite high. So you can see that we have just estimated 50 years if a person is living, then how much is the money? It's around 100 crores which come if 1% of the people survive. So now you see the treatment cost individual, and you can see the prevention. And so what happens if we do the screening? It's just 6 crores. If we do 12,000 beta thalassemia children are born, if we do the screening, only 6 crores are being spent. But if we take the total cost of the treatment, it's 240 crores. Now you can very well understand how we can judge out these kids that the treatment versus screening. So screening was more focused on in this area. So now you can see all these slides, and you can always see the cost estimate and transplant corrective surgery, how much it affects. What is the cost which comes for the effective surgeries? So this was also calculated because when you are drafting any of the guidelines or you are having some information about such things, then only the budget can be released to the state, which is important, and the state can also take advantage of these slides, so they can go ahead what exactly has to be done by the state level, at the state level. So our journey started with the technology, know-how, and means to adequately treat and control both thalassemia and sickle cell disease were available, but which was not initiated as an intervention for various reasons before 2014. So, step towards the journey of blood disorders. Guidelines for prevention was started in 2015 and disseminated to the state in 2016. Guidelines aimed at creating protocol for and benchmarks to improve the quality life of the patient. It also guide on prevention and control, which includes antenatal, prenatal testing to reduce the incidence of live hemoglobin disorders births, and state were requested to propose in their PIPs in consultation with the state health department. So why I'm saying that states were requested, because the funds, which was very important earlier, it wasn't there in the states. Some of the states were doing some part in very limited manner. So we wanted that these patients should not suffer, and we need to have this screening program to reduce down the births of these blood disorders patients. So now how we reach the aspirations is like 29 states have started with the program, and we focuses on prevention as well as the management of blood disorders. So counseling is the first part, which is very important. You avoid marriage between two careers, genetic counseling, community education and awareness, which is very important. And this has been achieved through the IC division of the NHM, and other people also, the communities like you people have done it. So this is a type of a community education awareness for us. Establishment, creating laboratory facilities for testing and confirmation of hemoglobin carriers at district level, which is very important. Like a person, a lady who's coming to a facility for basically for her antenatal checkup, so that can be taken care of by doing the CBC, and finally the confirmation with HPLC or electrophoresis, which is compatible with the states and the centers. Establishing regional centers, COE in state, with the facilities of prenatal diagnosis, which I said that it has been initiated, and laboratory facilities for DNA analysis, which is very important, and still it's a challenge for us. So I think most of the experts will agree that still it's a challenge. And screening, cost effective population screening as at the PSC level, as I said, with CBC, solubility test, electrophoresis, point of care device, genetic screening, HPLC, whatsoever. Prenatal diagnosis, where the both partners are carriers, where the option of termination in case of affected fetus, and extended family screening of all known detected carriers and the patient. So extended family screening is for meant for especially for those people who are already affected. Newborn screening, because we can always identify the carriers of sickle cell disease, and so it was important that we do the newborn screening, especially for the sickle cell. Adolescent screening was again an important task, and we started with the adolescent screening with the RBSK program, where the teens go and get their things tested for the school children and the adolescents as well. So information and education, which is very important for us, was that IC activities are being carried out with the aim that the community understand about hemoglobinopathies and treatment and prevention modalities. Mass communication media to incorporate with NHM, IC at national and district state level. Media activities, incorporation of messages regarding hemoglobinopathies within the NHM program, including information and messages about hemoglobinopathies in the school textbooks. Delhi state has initiated and school health program and adolescent programs, and PowerPoint assisted educative talks and educational booklets distributed to students during school visits. So this is important when we are going, we are giving these education talks to the people. So they have to understand that what exactly they, though they are sufferer, they are carrier, but they are not understanding their own status, health status, which is very important. So for the management of hemoglobinopathies, it's like you provide at optimal care to all thalassemia sickle patient at the district level, ensuring the blood bank facility. So blood bank facilities has been basically initiated, and the concern was that where we don't have no blood bank facilities, we have started establishing our blood storage centers, where we are also trying to have the put the components over there. The new blood storage guidelines, which are very much into pipeline and may can see the light within 2 or 3 months, you will see that the blood storage center will also have the component separation. The component will be put in there, will the components will be prepared at the blood banks, and the components will be kept at the blood storage center. So when I talk of components, that means the red cells, the plasma, and the platelets. So platelets, during dengue we also require platelets, and for plasma we understand that in hemophilia we require plasma. So iron chelation drugs and free blood are available to the patients. However, bone marrow transplant is the only curative therapy we understand, and is a well-established and accepted therapy. So identification of such centers with the help of the state governments. Now in UP only, we have started with two more centers. SGPGI was one of the center, and now another center has come up with in BHU, where we have already started with the transplant. Even in MP also, Dr. Munshi is there. He will also like to elaborate that we have two transplant centers over there also, and people from private hospitals are coming, giving their free services to go ahead with the transplant. Now, training, which was very important to us, was universal training module. We developed a universal training module, which is very important because I understand my physicians, because we don't have hematologists across the country. Even the pediatricians are not knowing the entire subject. So our concern was we have to have the universal training modules which are accessible on the sites also and can be taken up in the individual institutes. So like physician, pediatricians, for pathologists also, these modules are important. Increased feasibility of antenatal screening by training personnel of sampling techniques and help of the with the help of the tertiary care centers where they are known, and train healthcare personnel for delivery of genetic counsel services for family at risk. So now we have identified 6 training centers. That is, one is AIMS Delhi, then another one is in Calcutta, then CMC Vellore, then another center is basically SGPGI Lucknow, PGI Chandigarh. So these are the centers where we are started with the training, and some of the states have already gone through the trainings and having the privilege of understanding the program in a better way. So financial support for obtaining treatment regime, we are just trying to help through our PIP process. We are trying to help the states that the support from NHM is there for the initiation of these activities. Universal treatment cost across the country. We didn't want that. In some of the state we were finding that the treatment cost is so high, and but in some other state it is quietly reduced. So now we want that universal treatment costs across the country, and here everybody has to participate, saying that the companies has to give the nominal rates, whatever state we are giving in one state, at the same rate has to be given into other states. This it's very important that the universal treatment cost is there across the country. A system of surveillance and registry is being established to track and evaluate outcomes such as patient registered, how many patients are registered, number of careers, couples opting for prenatal diagnosis, number of careers detected, school pre-med state. So recently, I think Asmita will be informing about that 31 lakh people were screened, and out of that we find that around 10% population was affected. So this was a challenge to it. When we came to know, they also got a Guinness Book of World Record saying that the maximum screening has been done in Chhattisgarh. But the concern was that so much people have been affected with this disease. So this was not so known. So this surveillance and screening programs are going to help and tell us in a better way. Even in MP, they are going to start with this program very soon. I think within 2 or 3 days they are going to start, with Dr. Munshi will be elaborating it, because I know about these things because the government of India is able to fund for these screening programs in a better way for the screening as well as for the management of the program. So what we are doing for establishing of ICHS centers, because it's again an important thing that these integrated center for hemoglobinopathies and hemophilia are established, so the people go directly to the centers to get the in treatment done. And about the blood information, the e-Rakt Kosh is already there, which tell us about the which blood is available in the blood bank, and the thalassemia and sickle cell patient can directly enroll themselves to get the blood in the time limits. Informing community and about appropriate treatment and management option, making these available through public health facilities. So we want that maximum people should come to the public health facilities, which is a better option. So political will and advocacy, we all understand that is very important. A small CSR project is also going with Coal India, where 120 BMTs has been done so far. And this project was initiated with Coal India, still running. Due to coronavirus period, we have stopped doing transplants because this was difficult for us, because the patient were not able to move and all these things were there. So, but more PSU help is required to take forward step towards prevention and cure of these blood disorders. Because this money which what we the government of India is doing, and I'm finding with the states also, every year the money is increasing, the budget is increasing everywhere. And it is surprising that, and thanks to government of India and my senior officials who have really taken up this matter, and the funds are going in a larger scale where my states will people will tell you how much when the money has been given from GOI. So challenges are still that comprehensive care and management of tertiary care, including rehabilitation. Again, I am saying rehabilitation, which is a very important context for us, because rehabilitation makes a person in a well-being, well-organized way. Establishing hemopathetic stem cell transplant centers in the state, which is again a challenge. Augment facilities for stem cell collection and storage, again a challenge. I cannot say because in government it is not there, they only the private. And initiation of stem cell donor registry at the government's end, which is very important. You can see some of the this is the transplant picture, because this girl has been got the stem cell transplant done, and these are poor children. The BPL patients have been taken care, whose yearly income is less than 5 lakh rupees. So this is a project which has been taken up with the Ministry of Health and Coal India, and thanks to Coal India for this, that they have taken up this project, and 200 transplants has to be done. Out of that, 120 has been done, 18. But again, they are coming up with the new project where they are going to facilitate thalassemia transplant as well as the aplastic transplant. So Dr. Jena, be ready for that. I will be taking your help in this regard as well. And we all can work together to put together events. So I request you all that you all are needed in a better way to come forward and tell us your views about what exactly government of India can improvise in helping the hemoglobinopathies patient. Thank you so much.
Thank you very much, madam, for the detailed presentation. We are grateful to you. There was one question from Dr. Sanjeev for you. Does
Mhm.
Government of India is going to establish a dedicated center for hemoglobinopathies in the
Yeah.
state of Jharkhand or Uttar Pradesh? I
So
think
see,
Uttar Pradesh you have just mentioned.
Uttar Pradesh, we have 13, 14 centers, Dr. Sanjeev, 14 centers in Uttar Pradesh. Integrated, they are called as Integrated Center for Hemoglobinopathies and Hemophilia. In Jharkhand also, we have established three. Two are functional and one is still not functional. So another three, four centers will be coming soon. In every state, we have established, and across the country, is around 140 centers has been already established, that is integrated center for hemoglobinopathies and hemophilia, where the transfusion infusions are being given to the patients coming to the government facilities, and that too they are totally free of cost. None of the things are being charged in these government facilities and in our centers.